Okay, hello everyone. Welcome to week 1 of the Leadership Alliance Professional Development Workshop Series. My name is Dr. Taiese Bingham-Hickman, and I'm the Executive Director of the Leadership Alliance, and I will be moderating today's event. This event is a component of the Leadership Alliance Virtual Professional Development Series. The Leadership Alliance Executive Office and its partners created this initiative to ensure continuity of skill building, networking, and exposure to graduate programs for undergraduate and graduate students from across the country. Paired with our Wednesday evening workshop series, we hope to expose you to a discussion of critical issues, allow you to network with each other and our wonderful doctoral scholars, as well as develop learning approaches and skills for navigating your research careers. This evening, I'm pleased to introduce former doctoral scholar, Dr. Kisha Piggott. Dr. Kisha Piggott serves as co-director of the residency program for ophthalmology in the Department of Ophthalmology and Visual Sciences at Washington University School of Medicine, where she is also an assistant professor. Prior to completing her residency and vitreoretinal fellowship at Washington University School of Medicine, she received her medical degree and PhD in immunology from Emory University School of Medicine. During her fellowship training, she acquired expertise in the surgical and medical management of diseases of the posterior segment of the eye and ocular oncology. Her clinical research interests include the management and treatment of uveal melanoma. Dr. Piggott also participates as the principal investigator of several clinical trials investigating degenerative retinal diseases. Her ongoing commitment to inclusion and diversity in the medical field has been recognized through her work as a Diversity Initiative grant recipient, Katie and Howard Venable Awardee, and as faculty diversity scholar. Dr. Piggott is a diplomat of the American Board of Ophthalmology and has professional associations with the American Academy of Ophthalmology, American Society of Retina Specialists, Association of University Professors of Ophthalmology, and the National Medical Association and Women in Ophthalmology. So please join me in welcoming Dr. Kisha Piggott. Hi, Dr. Piggott. So we do have a number of questions that were submitted for you, but before we dive into the questions, is there any additional background about your education in terms of how you decided to pursue ophthalmology that you wanted to share with the students?
Sure, and thanks for having me. Welcome to all the students that are logged on. Happy to be here to answer any questions you might have. So from a background perspective, I always kind of just done what I liked. I've never been one of those people who knew exactly what they were going to do. My older brother's in medicine and he knew he wanted to be a physician. My younger brother's a pilot and he knew he wanted to be a pilot. I had no such premonition when I was younger. And so kind of just did the sciences and did languages and honestly did a little bit of everything because I liked a lot of things. And so I think having exposure to several subject areas and very early on helped me to kind of hone in on things that I liked, which in this case was science. And so I got as far as liking biology, and beyond biology, decided that's what's going to be my major in undergrad, and still didn't know exactly what I was going to do. And so at that point, also kind of dabbled in research outside of doing biology on campus. I had several research experiences through the Leadership Alliance, great experiences. And that, again, gave me further exposure, right? So at every step, I continued to take opportunities to get exposure to different entities in order to decide whether I was interested in pursuing that particular avenue. And in the case of the MD PhD, because I saw that question was on there, I, again, mostly did that because I didn't know what I wanted to do. So I hadn't been able to decide between medicine and the PhD. And so at that stage, still young, I just finished undergrad, thought, why not do both? And that way I will equip myself to be able to do whatever it is that I wanted to do at the end of the day. Once I was done with training, I didn't have to look back and say, oh, I wish I had done the MD or I wish I had done the PhD. I went in saying, well, I don't yet know exactly what I want to do. I have a lot of years ahead of me and I want to make sure that I make the right decision for my career path ultimately. Why not get that experience? And there's no way that I could envision that one degree wouldn't be helpful for the other degree, even if I decided not to specifically pursue the classic clinician scientist pathway. And so the way, specifically to answer your question, that I fell into ophthalmology, my roommate in medical school at the time takes credit for that, because after finishing the 4 years of graduate school, I came back and had to do 2 electives. And she said, oh, you should try ophthalmology. I was like, fine, why not? And so that's literally how I ended up doing ophthalmology. Ophtho is not something that, as many of you know, is included in many medical curriculums. And so I probably otherwise would not have tried it necessarily. And once I had tried it, the thing that I really enjoyed about ophthalmology at that point was the mix. So it's a very straightforward, clear, clinical meets surgical mix. I actually am in scrubs because I just ran out of the OR trying to make it to this talk on time. So I apologize for being a few minutes late. But really it was the blend of both entities and it's the exposure. So I think that's the take-home message, is that I took the opportunity. I didn't say, oh, no, you're crazy. Why would I do ophthalmology? I don't know anything about it. I said, oh, why not? Right. And so I think if you take that approach as you go through life, when opportunities come up, people advise you in different ways, your peers, it doesn't have to be a mentor, it could be your peers. Take a second to think about it. And if you can, why not? So that's how I picked ophthalmology.
Thank you. Yeah, and I thought this next question was interesting. So the question is, in your view, how important is collaboration and interdisciplinary work in the field of ophthalmology research? Can you share any experiences where collaboration has led to significant breakthroughs or advancements?
Yeah, so ophthalmology, again, and I can make my pitch this whole hour for ophthalmology for anybody who's out there who's also doing the MD. It is an amazing, incredible field. There's a lot of research. There are so many opportunities for investigation and for collaboration specifically, especially at an institution where I am, WashU. There are incredible resources here. And so between the research side and the clinical side, outside of the department. And so, if you end up somewhere at an academic institution, that is going to be one of the key things, making partnerships, not just within your department, but outside as well. So for example, I do retina, but I also, as was mentioned, I do ocular oncology. And so that is tumors that occur primarily in the eye. So they start in the eye, not in another part of the body. And so I have collaborations with other laboratories on campus where I provide the tumor sample. So I take biopsies from the eye tumors in the operating room, and the PhD postdoctoral fellows, they come up to the operating room and I hand off samples from that patient's tumor. And they use those tumor cells, they cultivate them in the lab, and they are investigating therapeutic interventions for helping to treat what we call choroidal melanoma of the eye. And so that's a great example of where I'm in ophthalmology in the clinical department, but we have collaborations with a basic science lab for some work that they were already working on. And so they kind of came to us, and, it's something as simple as providing human tissue, because it's something that is so translational and that needs a human clinical level translational model. And so I am able to provide that for them by working with them on the clinical end. And they kind of are working on the translational end.
Great. And if any of the students out there have additional questions about the fields of ophthalmology, there is a Google Classroom. So we would encourage you to, submit your additional questions and connect with Dr. Piggott. I'm sure she can talk to you about that all day long.
Yeah, and to also piggyback on that, so that's within the institution. So that one, of course, they're interdepartmental. So within ophthalmology, we collaborate within retina, could collaborate with glaucoma, so within specialties. And then I just mentioned within the institution, but then I also am working on a project with Duke. So we have a collaboration outside of our institution where, because ophthalmology tends to sometimes have an issue with the numbers of patients, because there's sometimes a small number of patients affected by the disease. And so in this case, it's a small number. And so we're multi-institutional on that front, working with Duke on a macular hole project. And so that's another example. The tumor project, same thing. So we have a multi-institutional project going nationally for a different oncology project. And so there's a lot of opportunity based on the fact that you don't see thousands of patients at one institution within retina and ocular oncology to collaborate within the department, within your institution, and outside of the institution as well.
Okay. We had a number of questions about diversity and inclusion. So here are a few questions related to that. What are some of the initiatives that you've helped implement to promote inclusion and diversity in the medical field, particularly within the field of ophthalmology? And a secondary question, in what ways are you able to commit to diversity and inclusion as a physician and a researcher?
So one of the biggest roles, I think, that ties into that question is that I am the co-director of the residency program. And so when I started that, I trained here actually at WashU for my residency and wanted to give back just in general to the educational and training process by being part of the administration. But two, also being the face of ophthalmology, the residency program. And so for me, being at that co-director level, just starting minimally at the application process. We have really upped in general in terms of diversity, making sure that we're looking at all. So I actually look at all the ERM candidates that are applying, which is not something that we did before. I was part of the leadership. And so, really paying attention to making sure that we're including people at the interview level. So I'm interviewing or inviting people to apply an interview with us that look like me. And so then beyond that, obviously having them see me when they interview. And so also reaching out to them and having them reach out to me with any questions or concerns they might have specifically as it pertains to the ophthalmology process, not just at WashU, but in general. And so for me, that's been a big way that I've been able to now give back to diverse groups now at the residency level. And then also I have opportunities. So I will have my students message me also all the time to come shadow with me in the clinic. And so I also am very open to having them come spend time with me in the clinic. And I specifically mean URMs as well.
Okay, and following up on that, in terms of your role as co-director, someone asks if you can please share some insights on effective leadership strategies in the medical fields, particularly when it comes to fostering inclusion and diversity. Yeah. So you already talked a little bit about obviously being involved in the interview process, but is there anything else that you want to say about that?
Yeah, I think it's a culture. And so I think, most of us know that we're in a time where a lot of academic institutions are very cognizant of this. And so there's a big push at the higher level. So from the chair down, or I would say probably from the dean down, not even the chair. So the dean being kind of over all the departments. And then I think it's important to be somewhere where the chair, so the chair of my department is very invested in this. And so when we have our interviews, he's also very cognizant and asks very specific questions about, are we really paying attention to the diversity. And diversity doesn't have to mean, they look like me. It just means that it's a diverse class, that they don't look like each other. And so that can mean that it's not a class that's all men, right? And it can mean that it's not a class that's all from the East Coast. And so for us, we go above and beyond, not to make sure that diversity just means that it's an ethnicity or a background or a race diversity, but it's a diversity of residents that are coming together to kind of create a class that can benefit from each other's backgrounds and cultures. And so I think for me, I've been lucky to be at an institution where the chair also embodies that culture and really fosters that environment. And so I think that's important, to be somewhere where, I was here before the chair. I predated him. But for me, it was important. It was something that he's echoed time and time again. And so to have the leadership echo that, I think to get the support at our level really is important to also move that forward at the med school and the residency level as well.
And a few of the students wanted to know, why WashU? How did you choose WashU? Oh, yeah. How did you end up there?
So I actually interviewed here for MD PhD and said, there's no way I could live in St. Louis for 8 years. So I had lived in Atlanta for that long, and it was just too small at the time. And so when it came time to look at residency programs, and I say WashU because and I did immunology for my PhD, the department here is incredible. And so if it were not for geography, I think I probably would have landed up here for the MD PhD component of it. And so when it came time again to interview for residency, I inevitably looked at and applied to WashU. And I came here, interviewed here, and this goes back to the culture. So that chair wasn't here, but there was another chair who was equally welcoming. But the culture at WashU, just so collaborative. You know, people ask that question about opportunities for collaboration. So supportive, so nurturing. I think nurturing is the best way that I would describe the WashU residency program. And in the 2 days or less than 2 days that I spent here, I could really feel that. And so when you interview, you're going to find that everybody has their own culture. All the programs have their own culture, and you're going to fit into that culture. You know, that's going to be a very unique and individual decision. And so for me, the WashU culture really kind of reflected what I saw myself. They take great care of patients, they work hard, they play hard. And so for me, that was important. They take care of a diverse group of patients, because in St. Louis, we're the catchment area for a lot of the more rural Midwestern states and cities. And so we take care of patients from everywhere, and we take care of them. So we don't, you know, deny care or look at the insurance. We have a clinic which is actually started and targeted to taking care of underserved patients and underinsured patients. And that is the clinic that the residents primarily actually run. And now there is an attending who runs the program with the residents. And at that time, we didn't have a dedicated attending, but that's an even kind of more beneficial aspect now that's been added. But this clinic was directed or targeted specifically for that patient population. And what was great about the clinic was that we had all the resources that the private patients or the private attending side of the clinic had. And so they didn't spare expense or resources because the patients were underinsured or, you know, or uninsured. And so for me, that really stood out, that the goal of one of the main aims of the department was to take care of patients regardless of background. And that's what we do to this day. And I impress upon the residents that, you know, our job is to take care of patients. It doesn't matter if they're quote unquote VIP or underinsured. For me, it's providing the best care that you can for every single patient that comes through that door. It does not matter what their insurance status is. And so WashU, you know, they're financial aid programs. And so they really do a great job of taking care of patients, taking care of everybody who comes in that clinic door.
That's great to hear. And in terms of, you know, how that's impacted your view of medicine and how you treat patients, I guess, so one of the students asks in the Q&A about your background, particularly studying across disciplines, including languages, and how that has impacted your work in medicine. Do you think it's important to have an interdisciplinary background in both STEM and humanities? What are your thoughts on that?
I actually think so. That goes back to diversity that I mentioned, that I don't think diversity should be, you know, there's been a lot of emphasis on that. It's important, but I think diversity should also include, yes, your background. And so a lot of medical schools and residency programs now are also looking at diversity of your education. So yes, you have to do or fulfill certain requirements for both the MD and then PhD. But outside of that, you know, we are interested in someone who took the non-traditional path. And so for us, that is a diversity that you're bringing to your residency class, you're bringing to our program, you're bringing to the faculty in how you approach patient care, because I think it does make a huge difference. And for me, languages, so Spanish was my second subject that I studied at Spelman. And for me, it was great while I was in Atlanta. Unfortunately, there aren't that many Spanish-speaking patients here, so I haven't been able to use it that much, but I do still often use it. And so, yes, language is a great one. So if you end up somewhere like New York, for example, Miami, and you've done a language like Spanish, then that's gonna, yes, be helpful for your patient populations. You can advocate a little bit better for them without having to rely on interpreter services. And so depending on where you end up, there are certain languages that will be beneficial. And then, like I said, depending on your background, you also really, I think, bring something different to the approach to patient care than someone who's done sciences their entire lives. And, you know, people see that. So patients appreciate that. And like I said, your peers and your colleagues, I think, can learn from that.
And we had a few students ask questions about the graduate school experience in terms of the PhD portion of your studies. So what were some of the qualities of a good PI that you looked for when choosing a lab? And did your time in medical school change and influence your plans for your PhD research? Any thoughts on that?
So I don't have to cast my mind back now 20 years. It seems like it's such a long time ago. So one, obviously, you pick a lab or several labs, because the way I used to do it, we rotated through several labs and then you kind of decided on one based on interest. Two, a lab where you think that the mentor, again, has been supportive. So you talk to people in the lab. So you don't just talk to the PI. And I have had people contact me about my former lab, about my PI, and I always mention to them, you should talk to the postdocs, the med students, the grad students in the lab, because they're the ones that are going to be able to tell you what their experience in the lab has been like before you come through the lab. So, you can have an incredible conversation with your PI, but you want to make sure that the PI is focused on getting you through your PhD and not just focused on getting you into the lab and having you be a second set of hands, for example, making sure that, there's consistent feedback from the PI, consistent meeting with the PI, that the PI is available to you if you have questions or concerns, that the PI is open to these questions or concerns, and basically that the PI is invested in moving you forward. And I think the best way to know that truly, besides what the PI tells you, is to speak to other people who have, one, graduated from the lab. That would be nice if it's not a new PI, and two, people who are currently in the lab. And I think not just the grad students, because I think you collaborate with so many people within the lab space that you also want to get feedback from the postdocs and people who you'll be working closely with in the lab about what that relationship is like, because I think you want to pick a PI who treats everyone fairly and is supportive of everyone in the lab and not doesn't particularly or specifically work well only with one subset of people in their lab. So that's what I looked for when I did it. And I spoke with people in my lab. And so you want to make sure that you're in a space where you're going to thrive. And I think the best way to know that, besides, like I said, speaking with the PI and getting a feel for what that investment would be in you, would be to also speak with people in the lab.
Okay. So you obviously are a very busy individual. You see patients, you're co-director of the residency program. So someone wanted to know also why you decided to pursue academia and become an assistant professor. So can you talk a little bit about that, and how are you balancing all of these amazing things that you're doing?
So that ties back in with the wanting to give back aspect. So as I mentioned, ophthalmology is small. So there's not a lot of, women in ophthalmology, smaller, it's getting bigger. And then I do retina. And so women in retina, actually, historically, it used to primarily be more commonly men that were retina subspecialists, and that's also changing. So on all of those fronts, me being in retina specifically is on the unique side. And so for me, now that I've kind of made it to the other side, I want to be that example for other people coming up behind me. That women, surely, we already know that we can do it all, but we can do retina, and we can be in academics, and we can be diverse. And so that's how I ended up staying in academics, because I also wanted to be involved with the residency program, because like I mentioned, we are the face of applicants coming through ophthalmology. These are students that are applying into the field that they will be doing in the future. And so for me, I think it was important to be on the front lines. And so that's one of the reasons that I agreed, because yes, there were all these things I felt. I had just started on faculty actually when I agreed to do the residency program co-directorship. And for a brief moment, I considered not doing it, because I thought, well, I just finished training and I needed to build my practice. And yeah, where was I going to find the time? But for me, I decided that it was more important to show my face, to show up. And so that is essentially actually why I signed up to do the co-director, and why I'm in academics, because I feel like I can answer questions for other URMs that are coming up that are interested in ophthalmology by being at this institution and in that position within the residency program.
Mm-hmm. And another student wanted to know, how earning a PhD alongside your MD impacted your career. Do you have significantly more opportunities than an individual who solely obtained an MD degree?
So that's, as I'm not sure, some of the students might know. So there's so much research now on the med school side, med student side. There's a lot of programs that are giving you that extra year to do research. So I would say that in my case, one, like I mentioned, I pursued the MSTP because I wasn't sure what I was going to do. And so I wanted to best equip myself so that I could do whatever it was that I chose to do when I was finished. And so the training process is long. So it's 8 years of the MD PhD, and then it was 4 years of residency. And then I did the chief resident year, so that's 5 years. And then I did a retina fellowship, which is 2 years. So you can see how by the end of that, what you think you want to do or what you thought you wanted to do 10, 15 years prior may likely have changed. And so for me, I think I kind of reiterate, but I still wanted to have that exposure because I didn't want to know what I wanted to do 20 years later. So in hindsight, the PhD has helped me because I actually didn't pursue the clinician scientist track, but because of all my collaborations on the research side, and because ophthalmology is such a research, it's really a wealth of research actually opportunities in ophthalmology. And having had the PhD background, yes, helps you to understand the literature. So not only to be able to come up with research ideas, but be able to read the research, review the research, and apply that to my patients that I take care of, and to work towards improving therapeutic options for these patients that I mentioned, especially on the oncology side, where we still don't have great treatment options overall for patients. And then even on the retina side, so for patients with diabetic retinopathy and a lot of the patients who are in that underserved and underinsured population, there are still many questions that we don't have answered yet, and many ways that we're still trying to figure out how to intervene earlier for those patients. And so having the PhD background basically helps you to understand how to formulate questions, how to attempt to answer those questions, and then how to use that data and apply it to the patient care world. And so for me, that's what the importance was of doing the PhD.
Okay. And so you mentioned the long journey, the long path to get to where you are. So one of the students asked, in hindsight, which is ironic because of your profession, but in hindsight, what are some of the preventable mistakes you made while acquiring your degrees? Anything that you want to share that was particularly difficult or that changed your trajectory? Anything that, any common mistakes, pitfalls, or anything like that that you want to share with the students?
I'm trying to think of, and again, I think because I didn't have like a specific goal, I don't know. I was able to pivot at every step of the way. So there's nothing that, because I feel like I chose wisely in terms of my specialty. I feel like I ended up exactly where I needed and wanted to be, and didn't know that I necessarily wanted to be 20 years ago. So that's a little tricky for me to answer based on, I don't have a specific area where I thought that I should have done something differently and it would have turned out better, because that's essentially what they're asking, right? And so for me, it was the opposite in a way, that I decided to try it and ended up liking it and ended up actually loving it is a better word for that. I can't think of anything off the top of my head for that one, which I think I've been lucky. And I think it depends on, I tell a lot of people this to kind of be happy where you are in a way. And so I've been one of those people where I've been happy where I am, including in St. Louis. Again, because I've loved my experience at WashU, and that's why I decided to stay on faculty here. And it's a good city. So outside of geography, for me personally and professionally, it's been very fulfilling to be here. And so I think if you can kind of move through life with that you're going to be happy where you are, then you won't necessarily think of anything as a pitfall per se, and you'll be able to say, well, maybe that was a pivotal moment more than a pitfall, and that I ended up where I needed or wanted to be.
I like that. So we had another question about, and you mentioned this in terms of the care that WashU provides. You're not looking at health insurance, you're trying to, make sure everyone has equal access to care. So in your role, how do you ensure that patients of diverse backgrounds are receiving equal treatment, regardless of, socioeconomic or ethnic background?
So I think it stems from recruitment, and most medical students, fortunately, when they go to medical school, they're going because they really do want to take care of patients. It's not because of the money. And so I think if we can continue to emphasize that and, reward that or encourage that at the medical school level, then it's going to inevitably trickle down through the residency program. And then in training, that's kind of where you get the most exposure to all patient populations before you branch out into academia or private practice. And so for me, I think it starts way beyond even med school. It kind of starts where you grow up, how you grow up. And so if we can continue to instill that, for me, my role is, I think this is important. And so I will stress that at every chance that I get to my residents. And, at some point you say to yourself, well, it probably is a little bit too late to instill or change the way that someone thinks about patient care. And so in my role, our job is to try to curate a class of residents that we feel is going to provide that kind of care. So when we interview residency applicants, then I am looking for that in those students, in those medical students, in various ways when we talk to them to try to tease that out. It's hard in a 15-minute interview, but we have a panel and there are different groups of people asking different questions that we think we can kind of gain some of that information from. And you can get a good sense of that too from the personal statements and from the letters of recommendation. So in my role specifically, I think the way that I do it is to try to curate a class specifically that I think is going to provide that kind of care. And then when they get here, emphasizing that. And we do emphasize it and to model that behavior. And so for the residents, you have to show them that you're willing to take care of patients who don't have insurance or don't have the premium insurance, because that matters for reimbursement. So the type of insurance that patients have matters actually, and you'll learn all about this once you get to the other side on the faculty side, but it does matter for our profit and loss statements, but it shouldn't matter to patient care. And so for me, I stress that it does not matter. The insurance that the patient has, I will see any patient in my retina clinic. Even if they don't have insurance, we'll figure it out. And so I think if the faculty can emulate that and really emphasize that, then the residents see that and they recognize the importance of it. And so for me, in my role, both on the residency program side and as a retina and oncology provider, that's how I try to emphasize that to our residents coming through.
That's amazing. Can you talk a little bit about you mentioned you went to Spelman, which is a small private HBCU. Can you talk about your experience there and how that prepared you for graduate school?
So Spelman was even more amazing than WashU. My first love, my first home away from home. And it was small. And so I think having gone to a small historically Black college, it also continues to encourage you to do anything. And so at a liberal arts institution, they make you do a little bit of everything. That's the other thing. So you're more well-rounded. So you get exposure to everything. And they really emphasize that, you can do and accomplish anything. And that's both while you're there, they kind of emphasize that based on people who have come through Spelman. And so just the history, the legacy of Spelman really, really encourages you as a student to strive to be the best and to strive to be able to do anything that you think you can do. And so the 4 years there was just incredible from an education standpoint, both academically and kind of just, like I said, the legacy of being there. But also they provided opportunities outside of Spelman, because Spelman is a small private college, and so they don't have a big research institution or opportunities there. And so they provided a research office where I was able to learn about opportunities like the Leadership Alliance for the summer programs. And so for me, that was important to be able to go to a specific office. I didn't have to figure it out on my own. So right after freshman year, I figured out how to get into more research using that research office at Spelman. And after that, every summer I was able to go to that research office and look at the list and speak with someone and learn more about the opportunities. And that's how I got my research experience outside of Spelman, because it would not have been sufficient, I don't think, to stay at Spelman and do research during the semester to be able to move on and be, pretty confident and a strong candidate for the PhD program. And so you really had to seek out other opportunities. And so even though they didn't have a wealth of opportunities at or on campus, they did have the resources to point me in the right direction. And so that's one of the benefits of having been there, is that they had a lot of resources for all the students in terms of providing information access outside of the institution, despite its own limitations.
Mm-hmm. And can you talk to the students a little bit about your summer research experience as an undergraduate, and specifically the impact of connections that you made either with other students in the program or with faculty mentors.
Yeah, so that was great. I did Leadership Alliance 2 out of my 3 summers. Again, don't quote me on any of this. This was quite a while ago, but both incredible experiences. And, you know, this program, the Leadership Alliance program, just incredible, providing that opportunity to study in multiple locations, right? And so it doesn't channel you or funnel you. And so you get the exposure, one, outside of your institution, but also to choose where you're going to go. And then to meet other people of similar mind from a diverse, again, going back to diversity, diverse institutions and diverse backgrounds. And so you do carry some of those people forward with you in terms of your peers and your mentors through life. And so for me, that was both experiences were, you know, really incredible. And importantly, the depth of the research experiences, right? So you don't want to go somewhere just for us. Well, you may say, I'm going to go somewhere for a summer just to say that I did something. But this program really did a great job of, one, pairing you up with a mentor that, again, is going to be invested with you, because you will see when you're on the faculty side, life gets very busy. And so it's hard sometimes for faculty to really be devoted, committed, and to show interest in an undergrad. I'm not even, you know, like, we're not even talking med student. Forget med students, we're undergraduates, so we know nothing. And so the program did a great job of putting you into labs where the mentor, one, was invested and interested, and making sure that you had a good research experience, because that was the goal. The goal is to help propel you forward, and to prepare you. And so you want to be in a program where research is the emphasis, and that you receive the skills while you're there, those 2 months that you spend in the program on the research side. So that's really why you're going. And then the icing on the cake is these relationships that you're alluding to, where you have a big group of similar, like I said, undergraduates from around the country, that outside of the research experience that you get to interact with, and that they go on to do, again, amazing and varied and diverse things when they're done with their training. And so you have those people as your colleagues for life outside of the experience that you've had for the summer in the Leadership Alliance program. So thanks to the leadership. Thank you.
Yeah, I was also in the program myself, so I see the value
yes.
as well. So I'm going to shift gears a little bit here, because we have a question related to AI, and I know AI is like all the rage with chatbot GPT and everything that's going on. So this particular question is in response to that. So the student asks, I'm interested in understanding the role of AI and machine learning in ophthalmology. How are these technologies being leveraged to improve diagnostic accuracy, treatment planning, or patient outcomes? Are there any specific applications of AI that you find particularly promising?
Yeah, so there are already several in rotation. So one of the main ones being diabetic retinopathy, which again is great for patients in an underserved and underinsured population, because a lot of diabetics don't have necessarily good insurance or good access to care. And this is through the use of fundus cameras, or fundus meaning the back of the eye. So these cameras have been placed in primary care clinics. And so I actually was involved with a study where they looked at the camera used here on our campus for a while. You put them in the primary care clinics, and then you use AI. So you feed images into the system of what diabetic eye disease looks like. And then AI is able to recognize these images and then provide now the primary care provider with an algorithm that tells them this patient does not need follow-up, and this patient needs to be triaged within the next month to a retina provider. So those cameras are actually in the community as we speak. And so that's been, a significant change. And so the thing with diabetes and diabetic eye disease is that the earlier you catch these patients, the better they do. And the problem is a lot of them don't have issues until it's pretty late in their disease trajectory. And so getting these cameras into those eye clinics for patients who have known diabetes and poorly controlled diabetes has been instrumental in trying to help these patients now access care. Because one, they don't know that they need the eye care. And so now you're informing them that there's an eye problem that they're unaware of. And then you're able to say, well, you can go to this location to see a retina provider. This is who you need to see to take care of your eye disease. So you can see how that like now accelerates their access to a retina provider and to early intervention, because that's the key with diabetic eye disease. Early intervention, a lot of these patients can do very well. It's the patients who have really kind of progressed significantly by the time they get to my clinic that it's a little difficult to control and reverse the eye disease at that point. So AI is here. It's alive and well in ophthalmology. And there are many other eye diseases that they're looking at. Tumors is another one where we're still trying to figure out how can we use it, because with tumors, there are a lot of patients who get sent to me that don't necessarily have a tumor, but they have a brown spot in the back of the eye. And again, AI would be able to help us here, where we feed in benign versus malignant tumors into the system. And these optometrists or other care providers who are not specialists in ocular oncology in areas that are more remote, because a lot of my patients come from other states and hours away. And so for those providers, you can see how that would be useful. They're able to triage and say, oh, this looks like a low risk lesion in the back of the eye. I'm going to watch this patient on myself. Or this looks like a lesion that's very concerning for malignancy. I'm going to get this patient down to WashU in St. Louis. And so we're not there yet for the tumors, but those are ways that we're thinking, looking forward to AI being able to help or enhance patient care and reduce the burden on patients to have to travel to care providers for diagnoses where, you know, they may be able to be managed for benign disease in their hometown.
Okay, and following up on that, you talked about AI. So what other methods or resources do you use to stay up to date with the latest advancements in the field? And how do you incorporate that knowledge to in your discussions with others, especially students?
So that goes back to research. And so ophthalmology, like I mentioned, is, you know, very ripe with research ongoing all the time. There's a main journal. It's called the Blue Journal. It's just called Ophthalmology, and it's the highest impact of all the ophthalmic research journals that are out there. So that's how we stay up to date. I actually am on the editorial board for that journal, so I see a lot of the articles come through just outside of retina as well. I'm able to keep up that way by being part of that board. And then outside of that, we have a lot of meetings. So pre-COVID and now post-COVID, the meetings are back up and running. So ophthalmology nationally, and then retina specifically. There are many meetings going on during the year where they're presenting this data. So there are a lot of clinical trials in ophthalmology. And so that data is presented at a large majority of those meetings. And if you don't go to the meetings, you can access the information through our Academy of Ophthalmology or through our Association for Retina Specialists. And so the information is really out there. So it's accessible in journal form, it's accessible in online form, video format, and then meetings in person to stay up to date on the data. And so the trials really actually for ophthalmology, we do look at that trial data and we will change management. There's a new medication for macular degeneration that you may have seen ads for. And it's a medication that's been shown to allow patients to go about 4 months between injections or treatment for their macular degeneration rather. And that's something that we're starting to integrate into our practice now. And so it is a field where you really are driven by the clinical data, and we do change and enhance our patient care by implementing a lot of the new data coming out from the clinical trials constantly. Retina is very good at that, and ophthalmology in general is as well.
Yeah, and you made a good point about also professional society. So I would say if there is an area of interest for the students out there, that, you know, definitely look for a professional society that aligns with the research that you're interested in. They sometimes will offer conferences and travel awards. And so that would be a great way for you to tap into that area of research as well.
And for ophthalmology, there's the ARVO is the one that's very research based, so basic science. ARVO is that conference for those of you out there that are interested. And so a lot of students do end up presenting. If they get involved in research earlier on, they will go to that meeting and present posters or a podium talk.
Yes, and the Leadership Alliance National Symposium will prepare you for that. So by the end of the summer, you should have a poster or an oral presentation that you'll be able to take with you to another conference. So that would be great. Yes. Another student wanted to know, and you touched on this a little bit, but how long did it take you to complete your studies? Were there any challenges or opportunities that either helped or slowed you down when reaching your career path?
So yes, 8 years for the MD PhD. And actually, that's a great question because in my case, I was a little bit accelerated because my PI switched labs. So it was actually a co-PI. Her and her husband were the PIs for my lab. She was my particular PI. And I had another co-med student. So he was also MD PhD. We both happened to end up being in the same lab, but he was under the husband and I was under her. And so they were moving the lab to Stanford. So you can imagine, and that was during my, let's say 2.5, 3 years out, probably around 3 years. So the question becomes, well, do we have to move to California? Because we weren't quite done, getting close to the end, but not quite done. And, many of you will know that there's always something else that you could do. And so in this particular case, it worked out for me that I wasn't moving to California, but neither myself nor my co-med student were, hoping to have to go. And so they, in a way, were able to accelerate our being finished or completing the thesis, because your PI also will say, oh, well, don't you want to work on this project or this project? And in this particular case, because they were moving geographically, and we had a discussion that it probably wouldn't be in our best interest to have to move out there, because that would then create a gap too in the amount of research you could do between the actual physical move that we could go ahead and finish. And so I finished in 4 years, which is not always the case. And so I think I got lucky there. And so that really moved me forward. So that was 8 years. So 4 med school and 4 of the PhD, and then 4 of residency. So it's 1 year of medicine before you do 3 years of ophthalmology. And then I did a chief year. So the chief year at WashU is an extra year. It's essentially a junior faculty position, but it's an extra year after your residency. And so I basically staffed under care of the first year residents and the third year residents in terms of the inpatient consults, doing the emergency room consults, doing all the trauma care. So all the surgical after hours trauma. So I had an extra year of that before I went on to do my retina fellowship, which is a 2-year fellowship. And so there are only two 2-year fellowships in ophthalmology. One is retina and one is oculoplastics. All of the other fellowships after you finish ophthalmology are 1 year. So that was my trajectory. And then I stayed on faculty, and here I am 3 years later.
Okay.
And still loving what I do every day.
Well, that's great. I wasn't doing the math, but it sounded like a long time. So
yes.
You still love it. It's great. So we're almost out of time, Dr. Piggott, but I did want to ask if there's a contact information that you wanted to share with the students, because we have so many questions lots of questions about the field of ophthalmology. So we're very excited about it. So there is the Google Classroom if you want to share a way to contact you, and we can have students continue to post in the classroom if their questions weren't answered. But I wanted to ask before we let you go here, what are your parting words? What are your words of wisdom for the students on this call today? Is there anything that they should do, or anything that you would suggest in terms of their summer research experience, or maybe they haven't yet received a summer internship experience, but they're looking? So anything you want to add about that?
So first I would say be flexible. I think if you're flexible, that will carry you very far. When I say flexible, meaning being able to pivot. So life may not go the way that you expect or plan or envision, and that's okay. And I think being able to pivot in the field of either medicine or in the field of research, really for your mental well-being, will be very helpful in making sure that you are thriving and that you're happy. And so the other thing is, it's hard at this stage because you kind of have to play the game, is what I call it, in terms of there's certain things that you have to do. Like you have to do research if you're a med student to get into a residency program. Obviously that goes without saying on the PhD side. But there's certain things that you just have to do to get through certain programs, and that's fine. Like just do them. But know that at the end of all the training that you get to do what you want to do. So you can basically shape your future trajectory after you've gone through all the motions, so to speak. So really try to equip yourself wherever you are and wherever you land up. Take from that what you can. And, not every experience that you're going to have with your PI, unfortunately, is going to be sunshiny and stellar and, the way that you hoped it would be. Some people have to switch labs move across the country. Sometimes you have to move with the lab. And so that's why I said be flexible, because if you're in or less than flexible, I think you will constantly be unhappy. And for me, that's what's worked out, that I've enjoyed or tried to enjoy everything that I've had to do to get to this stage in my life, including med school, including residency, having to be up at 2 a.m. and 3 a.m. And for me, it was that, one, I signed up to take care of patients. And two, I knew it wasn't going to last forever. And so at some point, you do get off the hamster wheel of having to do what other people want you to do for or to accomplish that specific educational academic goal, that degree. And so when you get to the end of it, you can do what you want to do. In my case, I did the MD PhD and wasn't expected to do the clinician scientist route. I think that's a good example. When I talked to the chair here, that never came up. He just asked me, what do you want to do? Right? A lot of places would have said, well, you did a PhD, don't you? Isn't that what you should be doing? There was never a question from him that I should have to do basic science because I did the MSCP or did the MD PhD track. And so for me, that's important. I got to do what I want to do. So I'm involved in clinical research. I'm involved with teaching. I'm involved with training residents and fellows and taking care of patients. And so for me, I now am doing what I want to do now. And so always remember that. Don't feel like you're pigeonholed based on your degree. That's the other thing. So yes, there are so many things that stereotypically you're supposed to do when you're done. And most people are going to end up doing that. And that's what we're trying to do. That's what the Leadership Alliance is there for. It helps support you to get to that goal. But also don't feel pigeonholed ever at the end of whatever it is that you do in terms of your degree or training based on what the typical route is at the end of that degree. Equip yourself with the degree for the information, the tools, the resources, the people that you meet along the way, and the skill set. And then take that skill set with you at the end and do what you want to do, what makes you happy.
Thank you. Thank you. And with that, we will conclude today's session. Thank you so much to Dr. Piggott for joining us today. Thank you to all of the SR-EIP students that joined us. This is day one, so hopefully Dr. Piggott didn't scare you too much with the amount of education that she did. But as she mentioned, you know, the Leadership Alliance is here to support you in your research journey and your education journey. So feel free to reach out to our office at any time. You all have access to the Google Classroom. So if you have other questions you want to follow up with us on, we're happy to take your questions. We will continue the series on Wednesday with our VPD workshop series. Until then, thank you so much, and we will see you all soon. Thanks, Dr.
All right, thanks so much. Take care.
Thank you.